Hey guys, this is Dr. Bodu from San Diego, California. Today we are going to talk about functional spine unit. And the spinal column can be divided into an anterior compartment and the posterior compartment. In the anterior compartment, you have the vertebral bodies, the disc, the end plates, and the ligaments. And it transmits about 70% of our body weight down to our legs. The posterior compartment it transmits about 30% of our body weight, and it mostly comprises of facet joints, including the facet capsules, ligaments, and muscles that are posterior spinal muscles. The ligaments, most commonly pain generating are a ligament flavum, interspinous ligaments, the capsule of the facets, and the supraspinous ligaments. So the pain generators, we talked about the disc, and then the neural structures, either dura or the nerve root. And then the structures are vertebral end plates, facet joints and capsules, ligaments, sacroiliac joints, paraspinal muscles, and tendons, and notably multifidus muscles. They provide a majority of the stability for the spine and the vertebral bodies, which morphic changes can cause pain. Treatments, spinal disorders. First, we always follow a conservative treatment, either with the NSAID or muscle relaxers, physical therapy, etc. Then it falls to a surgical or non-surgical. Not in non-surgical, traditionally the pain management, we do the diagnostics or therapeutic blocks. Either includes steroids or local anesthetics or ablations. With regards to the regenerative medicine treatments, I call it traditionally. We used to do a single structure or one level, which either we did biologics into either epidural space or facet injections or just ligament injections. But after the concept of functional spinal unit is a comprehensive targeting all the structure that are potential pain generators. And so in 2022, Dr. Akluri and I was one of the co-authors, published a, a prospective RCT for 12 months. It's an open label, and we use autologous BMAC for chronic low back pain due to severe lumbar spinal degeneration. And what we found was there was a significant amount of decrease in pain scores on these patients. And there was a decrease about 10 points of ODI, but 67% of the patient had the MCD for on an ODI scale. Um, so what it comes down to again is a decision making. Is your patient fit for a traditional or single level or single structure or a comprehensive functional spine unit approach? Now the second thing is the type of biologics. What are we going to choose? Are these patients going to use a PRP or platelet lysate or protein concentrates or bone marrow spirit concentrates? So it depends on the patient. Again, these are not paid by insurance companies, so finances comes into play also. And then the other decision is to a part of the FSU, are you including disc or not? So either way, for PRP, you need higher volumes of blood, at least 120 ml or most probably 240, and a high concentration of platelets. So you produce a PRP using high volumes. With the bone marrow, we target posterior superior iliac spine, very high concentration of bone marrow stem cells. And ideally, you want to do a multi-axial, multi-site aspiration. small volumes at each aspiration and aggressive aspiration so that you can get those mesenchymal stem cells or progenitor cells. And I usually get a total volume of 120 ml aspirates. So Dr. Eckler and I published our counts, and what we found was our total nuclear count using those kind of techniques came up to about 2.1 billion, and our um, colony forming units are very high, about 44,000 plus. Um, so the injection, like mentioned about, is a comprehensive care. Each patient may get anything about between 8 to 12 or maybe a little higher number of injections. Here in the picture, you see we have placed needles into two levels of facets, two discs, and and a SI joint bilaterally. So injection into those all the structures. Facets take very small volume. Very important to calculate, to plan how much are you injecting or how many levels and how many sites are you injecting. So facets traditionally take low volume, so which is again half ml per each site. Interlaminar epidural takes about two to three ml. Sacroiliac joints about 2 mLs. Transforaminals, we give about 1 ml of bone marrow concentrate. Now, when I inject muscles like multifidus tendons and multifidus muscles, or ligaments like supraspinous, interspinous, or iliolumbar ligaments, I inject about an ml at each side. Uh, Usually we are short of it. So what you could do for injection of ligaments, you can dilute or volumize with either using a PPP or protein concentrates to that area. So now post-injection, very important to talk to patient about expectations and injections because they need to have the time frame where in the beginning as they get better, it'll be a few months before you start noticing the difference. So bracing is very important for first 2 weeks. For the next day, patient can do activities of daily living and with the brace, of course, and also post-operative pain treatments with analgesics, very important. No recreational activities for about 4 weeks. Later on, I do augment these patients with either a laser or a soft wave after about 4 weeks. Physical therapy starts about after 4 weeks, and then by 6 to 8 weeks, they're pretty much having unlimited activity. They're going to ramp up to that. But thank you very much for your time.